care in the emergency departments during pediatric mental health crisis, and key standards of care metrics. Our presenter today is Angela Nguyen, who is a licensed social worker. Angela is an assistant director of pediatric clinical social work in the Department of Health, social work at Dell Medical School, and an assistant professor of practice at Steve Hicks School of Social Work, both located at the University of Texas at Austin. In her role, Angela is brilliant, and she does many, many things, but she is focusing to supervise pediatric social workers within the Texas Center of Pediatric and Congenital Heart Disease, Adolescent Medicine, and Texas Child Access through Telemedicine Program. She has extensive experience in implementing suicide prevention initiatives within hospital systems and integrating mental health into hospital-based programs, focusing on pediatrics and emergency department settings. I do want to remind everyone to please include your name, your credentials, and your affiliate organization in the chat. I'd like to keep track and make sure we get in touch with you afterwards. This is a webinar and it's being recorded, so we can share with others. So as you think of questions, please make sure to put them in a chat. Also, feel free to unmute yourself and ask those questions, as we most likely will get them from other folks who are going to be listening to this. So if something pops in your head, please don't be shy and put that in the chat and let us know your thoughts. And with that, I'll give you Angela Nguyen.
Thank you. I want to reiterate that this is really a presentation that we created based on feedback we received from our last cohort. And we really wanted to make sure that we were starting off your process with some key information. So if you do have questions, or if I'm using language that is jargon, you can just stop me and ask questions, or put that in the chat. So as Anna had said, our objectives really is to identify the different stages and really kind of go through them in a more, I think, concrete way. I think we have other presenters in the future that's going to go through and speak to it, more of clinical processes and kind of walk through the patient experience. That's more of an immersive experience. This is going to be more of a, feels kind of dry. It's kind of exciting for me, but just kind of the different metrics and ideas to think about as you're launching your project. So we want to identify the stages of care. And I'm going to talk through some key quality and standard of care metrics at each stage. And then we're going to talk about some resources at the end. The resources, there are a lot. So I was thinking that we could make that available in the slides. If we make the slides available, or send that out, because there's a lot of different resources for what we're talking about here today. The first thing I wanted to talk about, and some of you may be familiar with this, I'm going off the premise that we're all mental health providers, but not all familiar with emergency department language, key metrics, processes. So I'm gonna kind of just start us off today with a brief snapshot. So CDC released in October of this year a National Health Statistics report about what do our pediatric emergency visits for mental health, what do they look like? So over from 2018 to 2021, we know with the pandemic, there was some changes. Some of it was common knowledge. Other is just good information for you to know of, like, what populations are presenting. What we know is that about out of every 1,000 visits by a child or adolescent to an emergency department, about 14 of them, so 14 out of 1,000 are a child or an adolescent that is presenting with a diagnosis of a mental health disorder. And so that's about annually. How many are coming through per 1,000? So if you are working with an emergency department and you know kind of what their annual volume is, kind of know what their estimated number of mental health patients that should be coming through. And that will also allow you to gauge, oh, is there a higher number in our area than nationally? And if that's the case, why? So maybe that would be an area where you could look at it like, okay, are there deficits in the community? So then what are ways that we can better support our emergency department? We also know about the ages. So we all know that in general, teenagers are more likely to present to the emergency department. The 12 to 17-year-olds had a much higher rate than kids younger than 12. And then girls had about, I think, 4% higher rate. So slightly higher rate of presenting to the emergency department than boys. I think that oftentimes when we think, oh, kids are presenting to the emergency department, it's the ones that stick out in probably emergency providers' minds are the kids that are really hard to manage or the aggressive ones. Diagnostically, the majority of kids that are coming through the emergency department have primary mood disorder or anxiety disorders, meaning that they might be being triggered and it's a scary place. And so kind of thinking through, okay, we are going to support them. And it is scary when a kid comes through that's really aggressive or hard to manage. But there might be ways that you guys can support and work through that with people, knowing that in general, most of those kids have a diagnosis of mood disorders and anxiety disorders. The other thing is medication. So hearing that, also approximately 1/4 of kids received psychiatric medication while they're in the emergency department. So that would also be an area to talk to emergency departments about. Because if you think about it, and I'll talk about that in a minute, of disposition or length of stay, really thinking about when we give psychiatric medications, most of the time we wouldn't think that they would need to have a routine medication while they're in the emergency department if their length of stay is 4 hours or less, meaning that kids are probably staying longer, or they're using psychotropic medications to help alleviate symptoms while they're in the hospital. And then length of stay and disposition, I was going to talk about first. So the disposition, also, we talk a lot about kids boarding, but statistically, and this is just a snapshot from across the country, only 1 out of 5 kids are admitted to the hospital or transferred to a psychiatric hospital. So a majority of those kids are going home. And I think that they're not necessarily getting the spotlight of the boarding, or maybe kids are boarding in the emergency department and then going home after an extended stay. So that would be a story to get from your emergency department as well, of what is their disposition status of their kids when they're and what are their length of stay. So the wait to be seen. So a metric that the emergency departments often use is how long does it take for a kid to get into to see a provider? That's about the same for kids with a mental health diagnosis or not. It's about an hour. The difference is that there's a much larger percentage of kids who stay past 4 hours once they've been seen than kids with medical diagnosis. So with the idea that getting resources in there to provide the assessment and then the disposition takes a lot longer than the average kid. And then the payer source is generally Medicaid is the highest payer source for pediatrics of kids going to the emergency department, which again, I think is something that most people kind of know. All right, so this is a slide that you're probably going to get tired of by the end. So we kind of just outlined, these are things that when going to the different stages, thinking about what are the different standards of care, quality metrics, the environment of care considerations, and professions involved. Those are the things that in the emergency department will be important to kind of ask about and to look at ways that you potentially could be a key, like one of your key drivers in helping implement a program would be looking at maybe one of these things. So I'm about to talk through the care pathway, and I know that that's probably been introduced to you, but we're going to use that as our roadmap today as we talk through emergency department. And this is how I think about emergency departments. And I think that if you've worked in the emergency department or with the teams, this is kind of how they also see the care pathway. They think about it in stages. So when you think about the standards of care of each stage, the standard of care is not necessarily a medical term, it's more of a legal term, but it's basically, if you had 100 physicians or 100 people in a room, what do they think is a reasonable standard of care? So usually Joint Commission, CMS, different accreditation bodies have different standards of care, which is basically like, this is baseline, this is what we expect. And then there's the quality metrics. The quality metrics is the measure of the timely and effective care. So they're often looking at, how we're looking at the quality measures to say, how are we meeting these standards of care? So making sure that we can do things efficiently and effectively. And then environment of care. I know that we're doing an environmental scan, which is different than environment of care. When we talk about environment of care, we're talking about exactly that, the emergency department. We're talking about how can we keep kids safe, protecting them from harm, so safe treatments, safe procedures. This can mean everything to considering what medications we provide in an emergency, considering safety holds and safe rooms that we put kids in, and who's doing the safety holds, and what does all that look like if that has to happen. How will we do it? How will we create an environment that helps keep kids calm and safe? And so we'll be talking through that in each of the different stages, and then the professions involved. This is something that was brought up by some of our previous participants as well, is there are so many different players in the emergency department, and so many people who really are thirsty for more information. How can I do my job better? We know there's high turnover rates in the emergency department on all levels of staff. And we know that one of the major causes of burnout is not feeling like you have the tools or that you're trained to do your job. And so this would be kind of a way to highlight different people or professions that you could market or talk to better get an understanding of how your initiative might be, how you can be effective in helping them, both of you meet your goals. So the next slide is the care pathway. So this care pathway is in the critical crossroads packet that I think was shared with our resources. If not, this will be shared. And so we're going to go on this pathway and talk through the different stages for when a kid who's in a mental health crisis presents to emergency department. So for our care pathways, basically just a tool that describes and sequences how health professions manage clinical presentations. So there's a clinical care pathway for neonatal fever. There's a clinical care pathway for, asthma. There's different ones. And so best practice is that emergency departments have a clinical care pathway for kids who present with a mental health emergency. And so you want to have, there'll be goals for each stage, key elements, things to consider, and then, different ways that the team can work together. And this is, again, seen as best practices in improving patient outcomes. All right, and so that was hard to read because that's a lot of words. So I kind of broke out the different stages here to kind of show you the path that we're going to go on. So we start with triage, and then we'll go to screening, ongoing assessment, and disposition. And so those are specific stages of care that potentially involves different people. And for the most part, it might be in different areas, but it would have different stakeholders potentially. So we want to kind of think it through, what is the purpose of each stage, and how is the emergency department executing that? And are there any quality improvement metrics that potentially your team could be supportive of the emergency department? Because a lot of times emergency departments don't necessarily know what they don't know. They just know that they're struggling. And so the triage, to define these, is the routing of patient to emergent care. So this is generally I call, I think I was, when I was talking to Anna, like a quick look. It's not a full assessment. It's just basically like, I am assessing what I think is happening here. The screening is a more in-depth kind of, using evidence-based tools. Ongoing assessment is actually based off of the screening that you have, what the interventions are and what assessments are needed. So oftentimes I use the example of, if you have a kid that comes into the emergency department and they have high blood pressure and a fever, you've used screening tools to identify that they're sick. But what are they? You have to go back and blood tests or do x-rays. Those are the assessments that you're kind of doing. You're doing different things to kind of figure out what the actual diagnosis is. You're not diagnosing someone oftentimes in triage. Sometimes you can, or with the screening, but in general, it's, there's kind of this red flag indicator like, oh, this is something I need to look into. And then moving on to the assessment part of, okay, what really is this? Can I rule out some things? Can I kind of hone in into what I think the root cause is? And then disposition. And so this is with the requirements are that they have referrals, and then determining their level of cares. So triage. This is triage. Going back to that slide I was talking about. Triage time is critical. So if you think about a kid who's in a mental health crisis, it might have been their first outcry. They might be angry that they're there. They think that people overreacted. They might be embarrassed or ashamed. And so you're thinking about, and then if I am, and I've heard this from multiple, and I lived it in all my emergency department years, is suicidal ideation or aggressive behavior is sometimes very triggering for the staff of knowing what am I supposed to do in an emergency department, because there's not a lot of tangible things, and you have to make sure that you feel comfortable asking the questions and making a kid feel safe. So a lot of it is felt safety. And so one of the things with triage to think about is the standards of care are those care pathways. So if I see a kid that comes in and they look very agitated, what are my protocols? If I'm the front desk staff, if I'm a tech, for you all, familiarizing yourself with ESI scales. So that's usually the quick look. You're saying, okay, I'm going to rate you a 2, and a 2 might mean that you need a lot of resources and you need to go back quicker versus a lower rating, a higher rating. 3 or 4 actually it's not intuitive. So 3 or 4 is less acute. So they might sit out in the waiting room. So kind of being able to triage what, based on your hospital or your care pathway, is appropriate to set out in the waiting room and not be an elopement risk or have access to mom's purse and have access to lethal means. And that goes into the environment of care. One of the critical things to think about, like one of the takeaways with triage and ESI scales, is that this oftentimes is directly related to how they staff emergency departments and patient flow. If you've got 40 beds in your emergency department and you plan to turn over your bed every hour to 2 hours, and you have 4 psych kids who isn't turning, that needs a one-to-one sitter and is not moving, then your patient flow is going to back up. You're going to have a higher incidence of kids in your waiting room. You're going to have less staffing potentially in your emergency department because some are having to do different things, serve as a sitter or try to figure out kind of what next steps are. So kind of identifying, okay, what are the kids triaging, and how are they, what are their protocols and how can you help out with that, and coming through with an evidence-based, do you have to triage all kids who score anything on the suicide, if on your triage, they look agitated, what are some things that you guys can do? What are the pain points that they have? The words that often leaders in your emergency department would have with quality metrics would be door to doc. Door to doc is a quality metric that they measure of how long from the time I walk in the emergency department to when I see a physician is that. And so they want to decrease that number, definitely. And that was about that 1 hour time. And they're wanting to push it a lot sooner than that. Waiting an hour in emergency department, really, if it's any of us, is really feels like a long time. We want to make sure that another quality metric is that we're assessing kids properly and we're creating a trauma-informed environment, that we're not triggering them and making them more anxious. So looking at workplace violence, are there things that we can do that can decrease that anxiety and that stress for our patients and increase our staff's ability to de-escalate and read certain behaviors to make sure that we are keeping kids and staff safe. And that we're not moving into a more escalated situation. And then the patient satisfaction, families and patients feeling like they were heard and they were seen and treated with dignity. A lot of that with environment of care would be trauma-informed care. So creating a safe, confidential environment for whenever they're talking through things. And then the staff that is involved in triage is all of the above, depending on how a kid comes in. Oftentimes kids come in, so the data from that report showed that most of the time kids are not coming in through ambulances, or they're coming in another way. In Texas, sometimes they come in with the police. So there are many different ways. So thinking about that care pathway of, is there a safe triage place for kids who are coming in, a confidential space? We, for example, had created a different space where it was easy access to, if we were going to have them change their clothes, they were really agitated or coming in. We knew they were high suicide risk. If they were going to change their clothes into a gown, be able to take their inventory of their belongings, all of that kind of in a safe place, so they're not walking in the front door really agitated and kind of more embarrassed about what's happening or really upset. So those are kind of things to kind of think about as you're working through those. And then this is another area that I'm going to kind of try to highlight in all the areas, are these areas of focus. And I think that that's one of the things of the different buckets that we're kind of thinking about for what services could our PMHCAs offer emergency departments. And a lot of that is education, clinical support, or community outreach. And so thinking about some ideas just around triage, like if you just hone in on triage, education is of trauma-informed care. What does that even look like? What are some potential interventions? What are ways that they could set up triage or the intake area so that kids and parents felt safe? And it was that felt safety. And then because not knowing kind of how kids are going to come in, but mental health first aid for all staff might be an education point, because front desk staff might interact and see something that we didn't see. I know our EVS team sees a lot more than any of our clinicians ever see, and can give us like red flags of different things happening, or and so kind of talking about like, okay, what kind of education could be provided. And then that clinical support. So clinical support is around like consultation. Would be being able to be there as supportive to talk through, looking at their environment, walking through their hospital and saying, here's how I best support you guys to say, okay, this is the environment, this is how to keep these rooms safe, or to kind of talk through things to be considering. And then walking through different the psychotropic medications. So if they're doing that, figuring out what is the best care pathways, helping them develop those would be potentially one thing. And then community outreach. One of the things that is highly effective in the triage process is helping your partner come up with a what to expect when they show up, or even creating an expect process. So if a school or a primary care provider or EMS is coming, they know what they call ahead, so that the emergency department can be ready, and they know what information the emergency department is going to look for. That's going to be help best triage them and have a safe, calming environment when they arrive. If it is a crisis, if it's an outpatient provider sending information, giving that handoff to the emergency department so they know more information, you're making informed decisions. And then helping parents know what to expect. So helping the emergency departments create what to expect when you show up in a mental health crisis, what to bring, talking through all of those things, and helping them disseminate that to the people who refer or where kids normally come from. And then another thing that emergency departments don't generally know, some like if there's embedded mental health providers in the emergency department, but comfort with level of care. So talking with the community, if there is common screening tools that they're using so that you can have common language in those handoffs of we did the ASQ or the ask, they scored this, they weren't able to safety plan. What does that mean? And helping everyone kind of understand what those handoffs look like, and then also what the different levels of care are so that kids are not boarding unnecessarily. All right, I could talk about this all day, so I'm gonna move faster. Sorry. Oh, sorry, all right, there we go. Next step is screening. So this one oftentimes will go hand in hand with triage, but it is pulled out in this a little bit separately because it's not just suicide risk screening. It's really kind of things to consider when you're screening for trauma-informed care, for their presenting problem, kind of really getting an understanding of how to best support them as they're going through their process. So one of the things that we found in doing our ED stop and working with our other PMHCA is awareness and being comfortable, sorry, with the evidence-based screeners and protocols. That would mean, not just having them in the EMR, but really having training and knowing what the different level of risk means and having a good, clear care pathway along with those protocols. So helping staff feel competent in and if a kid says yes to a screener or endorses something, or parents have a concern, they know what to do, they know what to say, they know how to keep the kids safe and what that next protocol is. And that goes along with trainings and competencies with the quality metrics. Competencies are a big part of standards of care. So you can't just say, oh, we do the Columbia suicide risk assessment. We've did these trainings, and that's a part where your teams could provide those trainings. But then also we test their competency. So we know that not only have they taken the class or done the 30-minute training or hour-long training about how to administer it, they really know how to ask the questions. They know how to follow up. They know what the next steps are and why they're doing it. And that is a big part of making sure that evidence-based care is actually being effective. And the other quality metric would be patient flow. So when you're doing the screeners of, okay, how quickly do kids need to come back? Are we triaging them properly and are we keeping them safe? And then the people, I talked a little bit about psych safe rooms, RNs, social workers. The main people doing the screenings, based on all the information that all the different teams that we've talked to are mainly going to be RNs doing the screener. That would be your Columbia suicide risk assessment or the ASQ. They generally are doing that either at the bedside or in triage. And so those would be the big in quality improvement. People would be your main audience on screeners. Sometimes it's social workers. And then in the smaller emergency departments, it's the MDs, we've been told. And then the areas of focus, I'm going to click through this a couple times because apparently I put, are the education. A lot of feedback we've gotten from emergency departments are knowing the best practices of how to administer the screeners. So at a certain age, parents should not be in the room. Generally 12 and up, parents should not be in the room when those questions are being asked. How do you ask a kid who has developmental delays and feel comfortable that you're asking the right questions? How often do I re-administer the screener or reassess? How do I tell a parent what I'm about to ask? And then if there is a positive screen, how do I let them know what the next steps are? Like, do I feel really comfortable around these? And helping people really understand what the different levels of care, like why they're risky. And and how to make sure that we're doing the assessments properly. Clinical support is generally in this area, care pathway implementation, or changing kind of the, how do I document this? Or is it okay if oftentimes the nurses will say, well, the kids that are not suicidal, but they came in with suicidal behavior, if they were witnessed, having medication in their hand, saying that they had intent, and the intent, they were interrupted. What do I put? Can I put that that there was a recent suicide attempt, and being able to have like that supportive team members to talk through things with, and to talk about like what would be next steps in that care pathway, really kind of setting them up for success in those. And community outreach would kind of be the same thing as before, of just kind of common language and what to expect when people arrive, and having the resources of knowing who is referring. And that would be something kind of just partnering and asking, the emergency departments if they have that data. Okay. The next step is ongoing assessment. So ongoing assessment is often confused with screening. I think that probably you would not always confuse that, but a lot of times in the emergency department, the assumption ends up being that, oh, they scored high in the suicide risk assessment. That means that they need to stay here until we find a higher level of care. The reality is that's just an indicator that they might be high risk. The ongoing assessment is what's really important. And I think that gets stuck in the kids boarding and knowing, do we just stay the course until we find them the higher level of care, or what can we provide? I think the other thing with ongoing assessment oftentimes is, how do we, who is doing the ongoing assessment? What does that look like? So the designated order sets, some emergency departments talk about having designated order sets, and that's best practice in the ED stop bundles of, okay, here's what we standardly do. And so that people have an idea of, okay, if a kid comes back and they've screened high, here's the different steps. We're going to automatically put in a site consult. Or if they don't have that, the people who do the assessment. And then making sure that there's developmentally appropriate observation and interventions while they're in the emergency department. And so continuing to engage with the kids, making sure that they have good schedules, and really making sure that we have a good snapshot of what's going on and what would be safest for the child to disposition. So the order sets, making sure that protocol is being followed. I think that was a couple of quality improvement measures of other people, of other places, of saying, okay, what is the designated order set, and are we actually using that? And then the patient flow of how long is a kid waiting for, if they do telepsych, how long are they waiting for a telepsych consult? Are they only doing it on certain kids? What does that look like? What is the protocol for reassessment? So the kid's been there for X amount of time. Is there a process for reassessing to determine if that level of care is decreased and they can go home? And is there a good plan for that? And then constantly assessing access to lethal means and providing those developmentally and safe activities in your environment of care. One of the things that emergency departments look at is patient flow, right? So we talked about one of the quality metrics being left without being seen. So LWOBS is one of the key metrics they look at. So left without being seen is someone who comes in and says, I would like to have care. They check in, but then it seems like it takes too long, so they leave. So we really don't know what happened to those kids. We do not want any psych kids being left without being seen, because that's a safety risk. But if it takes too long to actually triage and then work kids through our system, then we'll have a higher rate of other kids who are left without being seen, as well as potentially our mental health high acuity kids. So we're wanting to make sure that the patient flow is effective and efficient, and that we are putting things in place so that we can provide the right level of care and the right team members at the bedside as soon as possible. So the goal would be that we could get a kid in, get them assessed, and if they could go home, be gone in less than 4 hours. Statistically, it looks like length of stay is a lot longer for our kids in mental health. And if anybody's been in an emergency department, that's a really long time for most of us to stay in the emergency department. So I think that, and the other thing that administrators are going to look at is budgets. So when a kid comes in and they stay for 7 hours in the emergency department, generally, and their psych, they probably only dropped one bill, which is the doctor's assessment, and maybe them walking in the door, versus other interventions that can be billed per diem. So that doesn't sound like a sexy thing to say, but it also then impacts staffing and revenue and everything in the emergency department as well. So if there are ways that they can be more effective and efficient in providing that care to the child, sometimes it's looking at like, okay, you're paying for a sitter for 24 hours, but if you could have just paid for a consult person to come in and see this kid 2 hours into their stay, how much would, more effective might this be? Or creating different partnerships. So just kind of problem solving different ideas for people who don't identify as being experts in the mental health world. So going to that is the different areas of focus. So in this area, education is training on evidence-based assessments. So identifying that the screener is not your assessment. TJC, the Joint Commission, expects that there's an evidence-based assessment. So oftentimes it's the BSSA through the ASK, or the SAFE-T through that corresponds with the Columbia Suicide Risk Assessment. So that would be if they scored high with suicide risk. The other, there are other assessments, clearly, if they do not score high, but there is a mental health concern, but the criteria is that there needs to be an evidence-based assessment. So providing education on how to do those assessments and how to interpret those assessments and look for different levels of care would be a great education. Oftentimes we're getting the questions around IDD and younger kids. So what is a developmentally appropriate assessment? How do I ask the questions? How do I really know if my assessment is accurate? And then what are some developmentally appropriate activities that are safe for kids who are sitting in my ER for 6 hours and really overstimulated? How do we train sitters to be able to identify red flags or show that a kid is escalating or de-escalating, and so that we can intervene quicker and not wait till it's a full-blown escalation? And then that different levels of care. So helping people really understand that risk versus protective factors, and what levels of care might be able to best support kids in their environment outside of the hospital. Clinical support oftentimes would be maybe setting up a clinical staffing time where the emergency department can call in and say, hey, I've got these kids in my emergency department. Can I staff these with you real fast? I'm thinking about sending this kid home. This is what's going on. Or I don't know what to do with this kid. They're not, and being able to really talk through and do some teaching along with that of different levels of care and different ways, presentations, as well as medication. And then the different ideas for intervention. So if a kid's been really escalated and they're like, I don't know, every time they wake up, they get really upset, we have to put them, restrain them, talking through, just helping them feel like they have more tools that they can talk through, use. And then that community outreach of resources first, and support for parents and children upon discharge. So sometimes parents need to start talking to places as soon as they get to the ER to try to figure out, do I feel comfortable with this? Can I look into different areas? And then that community outreach of just kind of liaison and saying, here's the different psych hospitals in town, or have you heard of these different levels of care? And really just trying to figure out, brainstorming with the different community and having that translation. So oftentimes my job is and was, I'm translating from the medical world to the mental health world. Oftentimes we're saying the same exact thing, but with different language. But then those two worlds would get very frustrated with each other. Like, they're trying to send me this kid who's not safe. And then the medical team's like, well, we're not competent to take care of them, and at least they're competent. And so there's this kind of like back and forth and this fear of, we're not going to do the right thing for this kid. We're not equipped. Everyone, and so being able to create that trust and talking through, okay, this would be the appropriate level of care. What are your concerns? Is oftentimes a really good way to liaison in the community and help work with the partners. Okay. I'm gonna try to be, we're almost there. So disposition. So this is an area that is not so fun. It's the scariest part for emergency departments. So thinking about if I do not feel like this is my area of expertise, and I don't have a lot of control over what happens to this child when they leave, it feels very risky to send a kid with any level of risk home, because the outcomes could be really negative. And so there is a tendency to hold on to kids a little bit longer in the emergency department because we don't know if this is the right disposition, or we've just screened them. And so we don't really know what would be a good fit upon discharge. And so we don't know if just, is it okay for this kid to go home and not see anyone and just give them a list of providers to call? How do I know they're actually going to call? And then kind of working through all the other kind of aspects of assessing and actually making sure that the care that you provided was the right level of care upon disposition. So that kind of patient flow process. So with disposition, we often think, we all know that we're safety planning while we're assessing, but it really is making sure that there is a discussion and there is a safety plan in place. Often the main evidence-based one is the SPI, the Safety Plan Intervention, the Stanley Brown, and making sure that it's actually being discussed with kids and families, making sure they have safety resources, and that counseling for access to lethal means occurs regardless if they're going home or not immediately from your emergency department, but just having that discussion. We found that having that discussion with families multiple times helps them be prepared more when they go home, because they will eventually go home with that child. The quality metrics that we look for is that patient flow. So there is that diagnosis to disposition kind of metric that comes up that they're looking for. Okay, so once we've identified what is going on, how fast can we get them to the level of care or to the resources that they need? So either to admission or to discharge. We also look at readmissions. So I think one of the things that really scares and makes doctors nervous is if you see a kid show back up in your emergency department that you discharged yesterday. What did I do wrong? What did I miss? Not wanting kids to have to come back because maybe we didn't provide the right interventions. And then the adverse events, I think, is often heavy on the medical providers, nurses, social workers, everybody's mind of, did I do all the things that I could to make sure that I was home and is successful, and that they don't come back having done anything to hurt themselves or hurt anyone else, or decompensated worse. And so the environment of care is safety planning at home. If you're transferring, what is a safe transport? Do we have safe handoffs? And then oftentimes, some of our partners have even helped the emergency departments talk to transfer centers or accepting hospitals to talk about how can we expedite what is information you need from us for those levels of care, and creating that trust and that relationship so that disposition planning is a little bit easier. Education training, I talked about the safety planning, making sure that the individuals in the emergency department understand level of care, access to lethal means, really creating that a robust community resources to talk with families to make them feel comfortable and engaged and empowered. The clinical support would be kind of the same thing of being able to staff, have a regular staffing time or just be available to staff a case. Most kids honestly probably show up after school. I know that in our emergency department, we would start ramping up our staffing starting at noon and then 2 to probably 11 was our peak psych time. So a lot of times when a kid first comes in, that staffing may not be appropriate if you're doing 9 to 5, but if they want to staff ad hoc, just talk through to see if they are getting the right feel, if they missed anything. The other thing that we've talked about is for disposition is potentially doing follow-up calls with discharged patients to understand, to be able to give feedback to the emergency department. Okay, they are doing good. Or, we gave this resource and it wasn't necessarily a resource that's taking new clients. So we'll continue to work with that. And then, or creating a safety net with, if there's general school districts in the area of the emergency departments that you're supporting, or primary cares, being able to say, okay, well, we're not going to call the patient themselves, but we'll call, we'll help create this safety net or transition plan with primary care physicians to be able to safely support them as they support the kids to come back to the schools. So just kind of working on how can we best provide that catchment or that safety net for the kid when they leave to help support and reinforce to the emergency department that they made the right plan, or to be able to give that quality feedback. Okay, and so like I said, here's just some basic resources, but it would be more effective if we can give those out to you. A lot of them are different agencies that have the standards of care, quality metrics, different dashboards that emergency departments use. And really, like going back to the idea of when we're speaking to our emergency department partners, speaking their language, understanding what matters to them, because oftentimes our language doesn't make sense, or they don't, or because that's not the world that they're immersed in, are meaning like mental health providers or the mental health world. So we all want the same outcomes. We all want the same interventions. What we don't often do is speak the same language. So understanding, okay, patient flow, quality of patient care, trauma-informed care, decreased workplace violence, left without being seen. All of those things are all safety concerns that everybody wants to make sure is being taken care of, but really being able to understand where the pain points of the emergency department are and what resources you can provide to help alleviate some of those pain points versus the kind of the basic, we can provide education on this, or different things that some of our PMHCA teams have felt like there's been kind of some stops. It's been harder to get your foot in the door because people are kind of, I can say this because I'm an emergency department clinician. Sometimes you have to have kind of a big ego, is what I say, to work in an emergency department. We have to feel like we've got it. So we don't want outsiders to tell us how to do our job. But at the same time, we want people to come in. We want our patients to get the best care. So that being said, I've talked a lot. What clarifying questions? And I feel like it was probably pretty dry. So some other people talk, other people ask questions.
Hi, I have a question. So the BSSA is a screener for people who score high on the Columbia Suicide Risk Assessment or the ASQ. Is that right?
So the BSSA is the assessment that goes along with the ASQ. So they don't have to, but the ASQ was created by a grant through the NIMH. So all of their resources are free online. And so they created the ASK, which is the screener, the ASQ, which is the screener, and then the BSSA is the evidence-based assessment that goes along with it, like the one that they created. Does that make sense?
It does. Yes, thank you.
And
And
so
then I have a general comment. So I feel like, I work at the Department of Health and Human Services and Public Health, and I work with Title V and the Maternal Child Health Block Grant. And I'm new to this emergency department flow and the work. And this is very helpful because, it's kind of a black box of what happens in emergency departments for me. And so this helps like clarify that. But then I also wonder what your thoughts are about public health professionals kind of engaging in that conversation and this work with emergency departments, because it seems kind of like a little bit out of our lane, but also the goal is to connect systems. So not exactly, but I'm just would like to hear what you think about that.
I think that's a general question. So if anyone else has thoughts, that you don't have to hear my voice anymore. I know that we have some past PMHCA people on here. Anyone have feedback on that? Apparently people like the sound of my voice. So I will say that we've had some with the Department of Public Health kind of, or the Department of Health be partnering. It does seem, it has been kind of the different kind of data points and kind of identifying, like, depending on what state you're in, like how much they want kind of that support. So I think that it is more identifying. I think in the past, people have partnered with like creating, not necessarily the department doing it, but kind of creating a group that is helping create some of these dashboards and help identify, okay, where are the gaps in care? Who are the kids that are getting sent, and how can we create programs that can help, decrease, our kids that are 15 and have Medicaid are getting stuck in the emergency department because there's no level of care other than inpatient for them, or, twice a month outpatient, and that's not the right level of care. Or what parts of town are sending kids to the emergency department, and can we, so I think it'd be more partnering, like, okay, what do we have and how can we create momentum and synergy, and start partnering with different groups to kind of step up and work with the emergency department. Does that make sense or no?
Yep, it does. Thank you.
Are there
I just want
more
to comment.
Yes, go ahead. Anne.
I was just going to comment how helpful this was, Angela. You talk really fast, but fortunately it's recorded. We're right at the point in Michigan where we're starting to explore what the model will be and have one partner sign up. So it's just still at the very beginning, but working out how can we adapt our PCP work to the ED. And so thinking about some of these things is helpful. We do a training for primary care providers on BSSA ASQ. So now I'm thinking about how do we adapt that for the ED setting. So it'll be helpful to think through that if there's anything different or the same for that piece.
I think one of the pain points that emergency departments that have not implemented it yet is tracking interventions based on the risk level, and feeling comfortable with that and saying, they score high risk, what should the interventions be? If they're low risk, do we do the same interventions, and helping people understand the why behind? You wouldn't have to, no risk. There's a reason there's phased risks, right? Like it's not, but I think people who are not familiar with it as much, all of it scares them, unless they're no risk, and then that's okay. And I apologize, I did talk a lot, or fast. I wanted to get through it for questions.
Well, great information. Totally fine.
You are a wealth of knowledge, Angela.
Thank you. And I think hopefully we can send out some of the resources so that you guys can look at them. I think it's just, it would probably be very welcomed for the places that you go and talk to, if some of the language, some of the standards from TJC, some of the standards that they're looking at for quality metrics, and helping understand that. I think that would help them feel more comfortable engaging, like, oh yeah, we are struggling with that, or we don't have a problem with this, but we're struggling with this.
Are there any more questions? I do have a few reminders, but I wanted to just give it a few more minutes for folks to put in questions or ask. Okay, hearing none and see none, we're gonna stop the recording.